everyone. I am Ann Curtis.
And I'm Susie Plows.
I'm from Maine College of Health Professions, and
yeah, I'm from the University of Nottingham in the UK.
Welcome. We're so pleased to have everybody with us today on this webinar about female genital mutilation and cutting. And we wanted to start by saying that we know this is a complex topic, and we're not here really to explore the cultural and traditional aspects of FGMC, but rather the care of girls and women across the lifespan who have survived FGMC. We want to also say that this information may be triggering and really difficult to hear and discuss. So we encourage you to practice self-care during this presentation and after. We will make this recording available, so we wanted to let you know that as well. And we also want to take this opportunity to publicly and enthusiastically thank Russ Brown, who is the Academic Technology Specialist at MCHP, for his guidance, his expertise, his support, and his patience. So we want to also thank in advance our speakers today who have generously offered to share their time, their experience, and their expertise so that all of us may become more informed about this subject and about how we can provide competent, compassionate care for survivors. We will have a brief introduction. That's what we're doing right now. We did want to point out, if you have any technical issues, my email and Susie's email are on the registration page. Just send us that and we will forward that to Russ, who can help with any of those kinds of issues. Following this brief introduction, we will have our speakers, and you see them listed here. Each speaker, or in the case of Shez and Amanda, 2 speakers, will have 30 minutes, and then Susie will facilitate 10 minutes of Q&A. So as we go along, we would ask you to put your questions in the Q&A. We've disabled the chat, and you have the opportunity in the Q&A section to upvote others' questions. So if someone already asked something that you wanted to ask about. Please note also that we do have a break built in. It's not good to sit for extended periods of time. We all know that, right? So we did build in a little bit of a break, but of course, take a break whenever you need to. Please also be advised that our speakers are free to decline to answer any question or any part of a question. So that's also very important. Alrighty, so I'm just gonna, I know it's not great to read slides, but we wanted to just establish some basic facts, which you may hear reiterated, and we expect that there may be some overlap across our speakers. So bear with me if you would while I read through this list of facts that we wanted to make sure was sort of part of our fundamental discussion. There are 4 types of FGMC. More than 230 million girls and women worldwide have been cut. And this happens often, mostly by people with no healthcare education or training and without consent of the girls and women. And according to the World Health Organization, it's done anywhere from birth to 15, although there's variance in that. FGM results in long-term physical, mental, sexual health complications. And one research study estimates that more than 44,000 girls and young women die from those complications each year. All FGMC is considered unlawful according to international human rights law. And we wanted to make sure that you were familiar with the term de-infibulation, which you'll hear about today. And that is the process of cutting open previously narrowed or closed vaginal opening in a woman who has had FGMC. So with that, I am pleased to introduce our first 2 speakers. Amanda Wickham is an FGM specialist midwife and community midwife. She has been a registered midwife for 18 years and has a dual role as community midwife and FGM specialist midwife. Her FGM role involves running a clinic for pregnant women who are survivors of FGM, which is a role she's enjoyed for 7 years. The clinic aims to provide culturally sensitive care for women during pregnancy, birth, and beyond. She gained her midwifery qualifications at Nottingham University. She has a postgraduate diploma in midwifery and a bachelor and master's in science. And much of her studies have focused on perineal trauma, particularly from FGM, and the implications during pregnancy and childbirth. Amanda has contributed to research studies, written various papers, including guidelines and training packages, and has a published article in the British Journal of Midwifery. Shez Davey is an FGM specialist midwife who has been practicing as a midwife for 23 years. She has worked in the acute trust as a rotational midwife between the antenatal, postnatal, and labor suite wards. Shez has worked as a community midwife, a teenage pregnancy midwife, and a safeguarding midwife specialist for over 10 years. She is currently an interim named midwife safeguarding for Nottingham University Hospitals. She is also a mother to 2 boys and nanny to 3 grandsons. So we're very excited to have them here today. Shez and Amanda, if you just let me know next slide, I will be happy to kind of move forward with your slides.
Okay, thank you. Can you hear me okay?
Yes.
Yeah, lovely. Shez, are you happy for me to just sort of go through the slides and then?
Yeah, absolutely. I will, I'll chip in, Amanda, with
Just interject with all the safeguarding. Yeah,
yeah, of course I
lovely.
will. Of course I will. No problem.
Okay, thank you. Well, I just want to say good afternoon to everyone, and thanks for giving myself and Shez this opportunity to discuss the work we do really in Nottingham to support women with pregnant women with FGM. So yeah, thank you very much. Okay.
If I can just echo, sorry, Amanda, what Amanda's just said is that, yes, no, thank you for the invitation and the generous welcome for us from Nottingham. And I hope you enjoy what we've got to say.
Okay, thank you. Next slide, thanks. So I know you've already sort of spoken about sort of what FGM is, but I just thought I'd do a very, 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 very quick sort of overview. But we've already done this, so just to say what FGM is and the different types of FGM that we see in women. So obviously we know it's a procedure to injure or remove or change the female genital organs, and as we know, it's very traumatic and causes harm in many, many ways. Okay, next slide, thank you. So again, just a very brief overview of the types of FGM that women may be affected by. So you've got type 1, which is the partial or total removal of the clitoris. Sometimes you'll see just the clitoral hood has been removed. Type 2, where you've got the removal of the clitoris and also either complete or partial removal of the labia minora. Type 3, where there will be some type of infibulation, so that is where you'll see the narrowing of the vaginal opening, which causes a seal. And that is either by repositioning of the labia or just where the cutting has been, just the healing of the labia, which heals and covers the vaginal opening. And then we use type 4, and that's really just to define any other procedure that cannot be classified as type 1, type 2 or type 3. So that's just any other type of injury to the genitalia. So that could be pricking, piercing, scraping, any sort of other injury that you might see. Okay,
I think it's important to add there, Amanda, that we ask all women, so here in Nottingham, when women book for their pregnancies, we ask all women if they've had any alterations, don't we, Amanda, of their genitalia. And it's important from my perspective to ask regarding piercing, because if we have a child under the age of 18 who's had piercing, the questions will arise on who's actually performed that on a child, and how can we protect that child further, what's actually happening to that child. So it's just to know that we ask all women at booking in their pregnancy in Nottingham regarding any alterations at all.
Thanks, Shez. So again, just a visual representation of the types of FGM that you will see, with obviously the green areas sort of indicating where the tissue has been removed, and the closure of type 3, which can be almost total closure or partial closure. Obviously, labia is, there's no such thing as a normal labia. So, I think it's really important when you're discussing with women the type of FGM that they've got is to Well, I certainly show them pictures of lots and lots of different labia, just to show that there is no such thing as a normal labia, because women have this preconception that the labia should look like this, should look like this, should look like this. So it's although I show women this slide in the clinic, I obviously try to tell them that normal labia is not a thing. Next slide, please. So at Nottingham University Hospitals, we have a referral pathway for pregnant women and non-pregnant women. Non-pregnant women are referred via the gynae pathway, so they will usually be referred in to see a gynae consultant. The referral pathway for pregnant women is that at the booking appointment, so when women first present in their pregnancy, the community midwives like Shez has indicated will be asked a question about whether they've had any changes to the genitalia, whether it's piercings, whether they know if they've had any cutting when they were a child. Obviously, some women are not aware that they've had any cutting. So if a woman thinks that she may have been cut, but she's not actually sure whether that has happened to her, then I recommend sort of say to the midwives, can you ask the women if they're happy to attend the clinic, just so that we can see and plan for the birth if they actually have had any cutting. So women that do say that they are survivors of FGM can be what we call midwifery-led care. So they can still stay under the care of the midwives and have their care out in the community. They don't have to be referred into consultant-led care. So they can attend the FGM clinic and then continue their care with the community midwives, which I think is really important, because I think it's really important not to sort of medicalise the pregnancy and the birth journey if we don't have to. So when they attend the clinic, we do, I say we, the clinic is just run by myself at the moment. Obviously, I work very closely with the obstetric team and with Shez and the safeguarding team and other, support agencies outside of the trust. But generally, it's just me in the clinic. So we basically just talk and have a conversation about when they had the FGM, at what age, where that happened. Talk about sort of any residual effects that might have had on the woman. So whether psychologically or physically there's any sort of residual effects there that she may need help with. So it's just doing that assessment of what she's experienced, any trauma that she may have gone through and may still be going through, and making a plan for her, really. So that is a plan for the birth. We do ask if we can do a physical assessment to see, determine the type of FGM that she may have had. Most women are happy for that to take place because a lot of women don't actually know what happened to them. And it may be that it's never been something that they've actually ever spoken about, because it's, it's something that happens and it's almost forgotten about. It's done and then nobody talks about it. So it's almost the first time for some women that they've had that opportunity to speak about their experiences, and they may not have ever been able to seek any support around that. So whether that's any trauma counselling or any peer support, so talking to other women that have been through what they've been through. And for some women, that's a good thing for them. Obviously, there are women that don't want to talk about it, and equally, that's absolutely fine. So, they may have, they may say, yes, I had it when I was 2 years old. It hasn't affected me physically or psychologically. I'm fine, which is great. Absolutely fine. So we do that assessment, and then that will enable us to sort of talk more about the birth process and whether the type of FGM that they've had is going to, going to have any implications for the birth. We discuss a birth plan. So if a woman has had infibulation, it's important to stress to women that it's down to choice about how she wants to birth her baby. So if she chooses to have de-infibulation prior to the birth, then we have 2 wonderful obstetricians at NUH that I can refer the women to undertake the de-infibulation. If women don't want to, then we can talk about whether they want to wait until the birth and then choose to have opening at the birth of their baby. Then again, that is their choice. Obviously, it's better for a woman to have it prior to the birth, because we know that the de-infibulation will be undertaken by a skilled practitioner. But again, it's down to choice what the woman chooses to do. She may even choose to have a cesarean because she doesn't want to be de-infibulated, and again, that's her choice, whatever she wants to do. So we make a plan for birth, that we can document that all onto her pregnancy records. We do also have an FGM template which we complete, which will help us to determine whether there are any safeguarding issues there. So usually through that conversation with women, you get an understanding about their thoughts and their feelings about FGM. But what the template does is it gives a really structured approach to the risk factors that may or may not be there. So if there is any questions that you may feel, for example, there is has the partner requested re-infibulation after the birth, or has the woman got close relatives that have undergone FGM? So there's various questions within that template that could highlight that there may be some risk factors there for the unborn baby, and that's what the template allows us to see from a more structured point of view. I don't know if you wanted.
There's bits in that template, isn't there, Amanda, where it asks that you tick a box that you've talked about the legalities around FGM and about FGM-IS, which is FGM information sharing. Information sharing thing. Exactly what it is the NHS spine. We can put a flag on the infant, on the female infant, to say there's a family history of FGM, and we don't need consent to put that on. It doesn't say who. But what that leads to is if that child, for example, is being brought to GP surgeries with recurrent UTIs, for example, it makes the GP think, actually, has this child had FGM performed? So it's really good prompt, I think, when that's completed, that you don't forget anything to ask that lady. And for me, it's around the legalities for safeguarding and about the FGM-IS. And that's something that I do post-birth. I put the flag on the female infant's records post-birth. But part of my role as well is to also support the hospital midwives who are not as experienced as Amanda, having those very sensitive conversations with women, because it's important we revisit it. It's important that we ask partners' views, their thoughts, wishes and feelings around FGM. Occasionally we do get a positive disclosure where partners will say, well, yes, we will have FGM performed, but when the children are much older. So also part of my role is the supportive discussions and supervision of midwives to help them understand and deal with the information that's being shared with them, because it can be quite traumatic for midwives too, to have those discussions and disclosures from parents. So it's really important that my team are involved. And I know we spoke about supervision when we met the other day, but supervision of midwives is something I provide, and we very often have these discussions through supervision in a very safe environment, for psychological safety of midwives as well, having to have those discussions and disclosures. Sorry, Amanda, I do that quite a bit, don't I?
No, that's absolutely fine, Shez. And I thank you for that, because if there are, sometimes you'll ask a woman a question and you're not quite sure whether you think that this unborn baby may be at risk. So it's good to sort of run by these answers to some of the questions with Shez and the safeguarding team to say, do you think that, what do you think? Do you think we need to do a referral to social care so that we can get more sort of safeguarding support around this baby? Most women will come to the appointment on their own. We don't have interpreters sort of pre-booked in the clinic with us, which a lot of the clinics, certainly in London, will have interpreters working with them in the clinic, but we pre-book the interpreters to work with us. So women will often have an interpreter with them, but will very, very, very often come on their own. And that, again, is an ideal opportunity to ask them the question about whether they're safe at home, and the domestic abuse question, which Shez will no doubt talk more about. But so that, again, is an ideal opportunity to ensure that, they do feel safe at home.
Yeah, and I will echo what Amanda said. Routine inquiry is what we say, and we ask all women. We should be asking at every opportunity in their pregnancy. It's a mandatory question in our electronic antenatal system that we use. So, and women want to be asked. So we're not discriminating against any women at all. It's just a routine question that we ask absolutely every woman, and our midwives are trained to deal with the answers. But Amanda's clinic, I think I would agree that it's a very sensitive, safe space for women to disclose. And we should be encouraging all midwives to see women by themselves at every opportunity, really, to ask that question. But as Amanda said, your clinic is a perfect opportunity to do that, because a lot of women do come by themselves to that appointment.
Yeah, and I think, like you were saying, Shez, the community midwives now, all the midwives within NUH are almost quite confident now with asking that domestic abuse question. When it first came out, we were all like, oh my God, that's a really sensitive question to be asking women. And I think we've still got that a little bit about the FGM question when community midwives are doing the booking appointment, is asking that question. So it's just trying to sort of suggest ways that the question can be asked without sort of coming out with the question, have you had FGM? Because a lot of women don't even understand the phrase FGM. They have no understanding of what that phrase actually means. So it's just a way of and if you sort of, if we can say that we ask this question to all women, so, whether you've had any surgery to your vagina, any, like Shez was saying, any piercings. So if we make it so that these women that have had FGM know that it's a question that we ask to all women. We're not just singling out women that we suspect is from a part of the world that may have been affected by FGM. So yeah, we do any sort of safeguarding referrals if necessary. We try to sort of keep language resources there for women so that we can give them resources to take away with them. We have a wonderful foundation in Nottingham called Majatu, who they provide a lot of training in terms of FGM to sort of different agencies like police, education. And they have a FGM survivors group. So women that may be struggling psychologically with what's happened to them, they can self-refer to Majatu, or I can refer them on their behalf. And it's great for women to have that peer support, because as much as we can be there for them and have those conversations with them, we're not affected by it. We can't possibly have an understanding of what these women have been through and what they're still going through in adulthood. So the Majatu Foundation provides that support for them, which is fantastic to have them as a resource. So like I say, we have a referral pathway for non-pregnant women, but that is via the gynae doctors. Non-pregnant women can self-refer to the FGM support clinics, which we have sort of nationwide, but the nearest one to us in Nottingham is Leeds, which is, I think it's about 70 miles away. So it's not great for non-pregnant women to seek that support. But again, places like Majatu can offer additional support if needed. Okay, thank you. Next slide. So this is probably more Shez's bag than mine. So just to look at, if we do feel that there are babies that may be at risk. So it's just identifying those females that are at risk and then having that conversation with Shez and the safeguarding team. So women that come from communities that still practice FGM, and we know that there are still many communities that still practice female cutting. We had a case very, very recently in Nottingham this month, actually, beginning of this month, where a very well-educated, I say gentleman, I use that term lightly, was sentenced to 4.5 years for arranging for a girl to be taken out of the country to have female cutting and marriage, and he was sentenced to 4.5 years. So that is the first conviction in, I don't know how many years, probably about 30 years. So that was wonderful news, and it obviously hopefully sends out a message to people that want to procure FGM that it's not tolerated and it's child abuse. So just quickly looking at the points. So communities that are less integrated into British society. So any female baby that's born into a family where the woman has undergone FGM. Female child who has a sister that's undergone FGM, and any female child that appears to be withdrawn. So obviously this doesn't, for us as midwives, this is more from sort of an education point of view, in school, signs to look out for when they're in school. I don't know if there's anything.
No, I'm just going to say, correct me if I'm wrong, but I think was it 2015 that mandatory reporting came in, where any health professional has to report a female who has had FGM or are they believed to be at risk of FGM, is to report it directly to the police and make a social care referral. That was from 2015 onwards, and we're all well aware of that. But for me, it's really important to identify those females at risk and make those referrals into the local authority as soon as possible, and in a supportive way, not for telling families that actually this child needs to be removed from your care. It's about supporting them and educating families who still practice FGM and understand the trauma that the female may experience at the time and in later life.
Lovely.
Anything else, Amanda?
No, that's fine. Thanks, Shez. Next slide, please. Oh, just I'm going to quickly run through these because I'm well aware that we're approaching the end of time. So what we've already discussed about stats about the 200 million women and girls worldwide have undergone FGM, mainly between 5 and 8 years, but that can vary very much, very wide variation there. And then approximately 10,000 girls under 15 have migrated to England and Wales are likely to have undergone FGM. Stats are a little bit dated, 2016, but haven't changed a great deal since that time. Okay, thank you. Next slide. So just a little bit about sort of local data to us in Nottingham. So we rank 9th in the terms of highest prevalence outside of London. 190 newly identified women with FGM within our area between July and September 22. Almost all women are identified in the healthcare setting, which I suppose isn't surprising, really, mainly midwifery and obstetrics. And I don't think that's really a surprising bit of data. The FGM clinic at Nottingham University Hospital's clinic, we see approximately 150 pregnant women yearly, which is a high number, but you know, if you look at the clinics in London, there are massive amounts of numbers, and they have holistic clinics where they have counsellors, they have interpreters, they do defibrillations. So it's in the clinic, so it's a very holistic clinic. But we see approximately 150, and then we've had 15 defibrillations that have been undertaken within the Midlands area, so not just Nottingham, but obviously this is data for the Midlands area between July 22 and September 22. So as you can see, in London they had 165 in that time. So just a little bit of data there. Thank you. Next slide. So I think you were touching on this, Shez, about the law. So it's been illegal since 1985, and this law was replaced in 2003 because there were certain loopholes within the initial legislation where girls were still being taken out of the UK, out of the country to have FGM performed. So it was replaced in 2003 and sort of stated that FGM was in fact a serious crime and carried a prison sentence. So, as we know, it's illegal to sort of to perform FGM within the UK or to take a child abroad to have the procedure done. So, just a little bit what I said about the Serious Crime Act. So that was also made an offence, and it protects the anonymity of victims as well. And it also it's an offence to protect girls. So, you know, parents that allow their children to be, you know, cut by someone else, or to be arrangements to be made for them to be taken out of the country to be cut, is also equally part of that Serious Crime Act. And then what Shez was speaking about earlier, the mandatory reporting. So all professionals have are required to report to the police any child, so any girl under 18 years old that has had FGM performed or is at risk of having FGM performed. And there is also the FGM protection orders that can be put onto a child and anybody can apply for a FGM protection order. It doesn't have to be a professional, it doesn't have to be a social worker, it doesn't have to be a health professional. It can be by any person that thinks they may be at risk of being subjected to female cutting.
What this does, Amanda, as well, isn't it? It protects, it helps, supports parents who feel that they are unable to protect their own children from other family members who might want FGM performed on a child. So it's actually there as a supportive measure. And I've certainly worked with families where we've done that, where the mother and the father have been here in the UK and have said that they feel that they can't return to their home country because they can't protect their child. So we've actually worked really closely with families in a supportive way to help them protect their children, applying for FGM protection orders for their child, so the child can't be taken out of the country. So it's really important that it works as well for families.
Yeah, I agree, Shez, and this is sort of this is sort of part of the conversation that we have with women when they come to the clinic, whether, you know, a mother and a father can be totally opposed to the practice and are very often horrified at the fact that you are asking the question about whether, you know, it's what their opinions are of it, because they are absolutely horrified and they would never perform FGM on their children. But again, they will say that there is pressure from family members because the elders in the family are still very much tied to that tradition of cutting. So they may, like Shez said, they may need that support to help to protect their children. Thank you. Next slide.
I'm just going to point out you have a couple more minutes before we move to Q&A. I could keep listening all day, but I just want to keep us on track.
Yeah, so again, just a little bit more about which we've spoken about. So it's mandatory for all professionals to report girls that have or may be at risk of FGM, and we've already spoken about the FGM protection order. Okay, thank you. Next slide. So do you want to talk about this bit, Shez, because it's more sort of your bag?
Yeah, so we've recently changed our FGM guideline, and I've worked with Amanda on our guideline. There was a change in the local authorities' procedures a number of years ago to say that they wanted to be informed about all female infants born to mothers who have had FGM performed. And the procedures do feed into our guidelines. And myself personally did not agree with that, because we're sharing in personal data with the local authority, and I think we're really good characters, a judgment of characters in terms of whether we feel that parents aren't being open and honest with us as midwives. So we didn't agree with that, and there was talks over a number of years, and that's now been reverted back. So we now no longer make a referral for all female infants born to mothers who have had FGM. However, we do encourage our midwives and through supervision support them in maintaining their sensitive questioning of mothers and indeed fathers. However, they do tell us about all female infants born when mothers have had FGM performed, because, like I said, we do the FGM information sharing flag on the national NHS spine.
Okay, thank you. Next slide. Thank you. Oh, so you spoke about that, Shez. So that's the FGM information sharing. So that's just, like Shez say, a way of safeguarding girls if there is a family history of FGM, and that stays on the child's health records until she's 18, I think, Shez.
It does,
is that right?
And then it drops off. Yes.
Then it drops off. So
it's like an alert.
And most parents, I think we have had occasional families that are opposed to it, but it isn't an opt-out. It's not something that parents can opt out. So we have had a few, I think, Shez, that a few parents that have not been too happy with that. But I think with discussion, they understand why it's there.
And on the whole, it's well received, really, isn't it?
Yeah. And then we just have to put any woman that we see who has been subjected to female cutting, we have to put all that data onto this data set, which is part of NHS England. And that just helps to give a very, very good overview of women, types of FGM, where these women are within the UK, and it just helps for NHS to plan services surrounding where these women are within the UK and what they have been affected by. Next slide, please. And
it's my honor to introduce our next speaker, Shamsa Araweelo, who's an FGM speaker, survivor, and activist. She's a survivor of gender-based violence, including female genital cutting. She's an activist and speaker who works to educate others about FGC and works to support survivors. She's the founder of Garden of Peace, where she works to end FGM and honor-based violence. This year, she was awarded honorary fellowship at the University from the University of Winchester. She is an inspirational speaker and mother. And if you'll give me a moment, I will bring up her presentation.
Thank you guys so much, and please do stop me because I tend to talk a lot. So if I'm not reeled in, then I'll just have you guys here forever. Thank you for the introduction. Can you guys all hear me? Okay. Okay. So I am a survivor of female genital mutilation. I am an advocate as well as a mother, a professional, and academic, because I have to say that first. And the reason why I say that is because my whole existence isn't being a survivor. And a lot of survivors, especially before I started speaking out, I realized that there's quite a lot of dehumanization when it comes to FGM survivors. The focus tends to be the practice itself or the day of the cut. Beyond that, nobody cares. And it's about time that FGM is humanized, because we are human. The fact that we even have to say humanize FGM survivors is absolutely ridiculous to me. But, you know, I felt like it's my responsibility to speak out against FGM, teach young women from my community that they have alternatives, that they have choices, that they can obtain control of their own body and autonomy, and they deserve to have control over that. So today I am going to speak from a perspective of a survivor and social activist, but focusing on FGM survivors. And I will tell you my own story as well. So just trigger warning from here on out, from here onwards. Next slide, please. So often when we speak about FGM, I've noticed that the focus tends to be one of 5 things. The day of the cut, the prevalence, which is usually the focus is Africa, the Black community, when it's a breaking story, when there's a fresh story. After that, it kind of dwindles down and no one pays attention anymore. Or the focus is it's a woman-on-woman crime, which is far from what is true. So we're going to move away from that today, because I don't want that to be the only focus. So when it comes to female genital mutilation, it sees no color, it knows no race, and has no religion. It can speak multiple languages, and the classes, because I think often the perception is it happens to poor women, or women in extreme poverty, women who are not educated, but it also happens to women of very high class, amongst the wealthy, the more considered educated, and a lot of girls, especially in countries like Singapore and Indonesia, it happens at a very, very, very young age, where they don't even remember haven't gone through FGM. And then when they find out later in life, everything, not necessarily their memory might not come back because they were babies when it happened, but is now living with the knowledge of having FGM, knowing that your family took the decision to either take away something or to cause damage when it was never necessary, you know? Next slide, please. When we consider FGM survivors, we don't look at the intersectionality. We don't look at what are the limitations, what are the blocks that have been put in place out of no fault of their own. For example, their limited access to resources, education, and healthcare. When I say that, there was so much that I did not know that I was entitled to in terms of healthcare, especially living in the UK. So, for example, between the ages of 9 to the age of maybe 27, I was not taken serious by health professionals. I did not know that I had resources available to me. I lived with my pain, being told that there's nothing that can be done for me. And another thing that I've noticed is there's not a lot of person-centered care. A lot of women, all of us are put into one category as if we all suffer the same complications, the same experiences, like we have the same ideas or opinions, or we are individual human beings. And I always say this, I was cut with my daughter, astaghfirullah, not my daughter, never. My sister, my older sister, and my little cousin. And having to be forced to watch them undergo FGM, it's a completely different type of trauma that came along with FGM. Having to watch them scream, having to watch them fight whilst your own family is holding them down, shoving pieces of cloth into their mouth. It's like a nightmare. Like even if it's depicted in a horror movie, it still won't be realistic. That's how bad it is, you know. And all of us who experienced that cut on the same day, I can guarantee you my sister has a different view of it. I have a different view of it. And my cousin has a different view of it. They might have experienced a difference. Some of them my cousin might have internalized what was happening and accepted that it's something good or useful for her. The gender inequality that women face already is part of the intersectionality. Just because we are women, especially Black women, then when we're talking about, for me as a Black woman, a lot of the pain and insecure, like the complications that I was going through were easily dismissed. My pain was not seen as pain. Even when I was a child, I went to a doctor when I was 14 years old because I was physically ripping, because I was physically sewn together. And when I say sewn together, I was sewn together when I was 6, which means by the time I was 14 years old, that's healed scar tissue, which meant because the period had nowhere for the blood to come out, it started accumulating inside of me from the age of 9 to the point where it was cutting through my skin. When I was I told my mom after months of keeping it a secret, because I thought, oh my God, they're going to assume that, you know, I'm a hoe or a slut or whatever, you know, just gagging for it. And she took me to the doctor after telling her, because she thought I either been sexually assaulted, I had sex consensually, or I did something to myself. So when I was taken, the doctor, who was a female, looked at me, saw that I had a scar tissue that has healed shut, damaged scar tissue, the visible effects of FGM type 3. And all she did was confirm my virginity and say, here's some paracetamol. You know, this happened because, you know, her period needed somewhere to come out. That is it. And I was sent home at 14. And I know that there are 14-year-old girls who are, even till this day, are not taken seriously, because some doctors will say, oh, a doctor could go a lifetime without seeing FGM. But if you don't know what FGM looks like and you have not had thorough education, how are you going to notice that this woman has had FGM? Because I can guarantee you a lot of women don't make the link between FGM and what they experience. They experience, next slide, you'll understand. I think I'm getting ahead of myself. Next slide, please. Okay. Out of these women, I know it's AI, but out of these women, who do you think is most likely to have had FGM? I would just want you to look at the faces of these women and just think to yourself, who is most likely to have female genital mutilation? Next slide, please. Because sometimes the answer will surprise you. And here are, and actually I want this to kind of be interactive if you guys really don't mind, but I want you guys to take a guess for me. Out of these little girls, who is the FGM survivor? Anyone?
Is there only one?
I can't tell you. So just looking at the picture, if you think there is one or two, which of the two do you think it is? If you think there's three, which of the three do you think it is?
Can I have a guess? Shall I
Of
guess?
course, it's a guess,
Middle
yes.
left. Middle left.
Okay.
The middle one. So the middle line, correct?
I think middle left.
Okay.
I think
Well,
all of them.
But if
I think all of them.
Someone said all of them.
if FGM, if female cuttings are worldwide, as we know it is, it could be all of them.
Yes, true.
Anyone else?
I was going to say probably the bottom right, the top right, and the middle left. And you can probably see there's some bias there in that I've chosen women of colour.
Yeah.
And I know it doesn't just apply to women of colour, but I know the prevalence in different countries, and that's what's guided my choice.
And there's no judgment in that at all. The whole point of education is so that we can have these conversations. But to tell you the truth, the only person that is not a survivor in this picture is my daughter, who is the middle, like the two middle photos, but right at the end. That is my daughter. No, the end. Yes, that one. That is my beautiful little girl, and she is not an FGM survivor. But every other one of these young girls are FGM survivors, including the two white women, little girls, who are now beautiful grown women. So it just really comes to show that there are so many survivors who are being missed, who are not being seen, who don't even categorize themselves as FGM survivor, because the world doesn't categorize them as FGM survivors. The world doesn't look at them and think, oh, you're an FGM survivor. They look at me and think, yeah, it's possible. But they could look at a white woman and they would still be like, no, how is that even possible? But it is possible, and it has happened. Next slide, please. Okay, this one talks about the names. In various countries, we have different names. If the people that you are taking care of do not understand the concept of female genital mutilation, maybe use female genital cutting, because the cutting is more like, it would click more. If you say, have you undergone female genital mutilation, and she is of a generation that is older, then she's not gonna make the click. Or if she is a refugee and she's new to the country, if she has language barriers, she's not gonna understand what you are talking about. I should probably say no. But in my country, it is called Guditan and Sunat. The one that my mother had was called pharaonic circumcision. But even just within Somalia, we have 4 different ways of saying it. So it's very important that the person understands that what is happening to them in terms of complication is linked to this, and that the topic of female genital mutilation that you are outlawing, that you are fighting against, and you're trying to end within communities is what they have experienced. They have to make that connection. If they don't make that connection, they will not seek resources. They will not seek medical attention. They will not get any education, because what you're telling them is, maybe in their mind, they just think, oh, this is the Western's version of trying to, corrupt our mind, or da, 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 da. But when you humanize things and you use language that they can better understand, then you will be more likely to capture their attention. And I think these names should be incorporated into leaflets and I don't know, anything that the hospital could give these women. These names need to be incorporated. And these aren't the only names. I'm pretty sure there are over 100, which is crazy for just one practice. So FGM is not going to cut it. And we get into the juicy parts. Next slide, please. This is where I tell you my story, my pain, and talk to you about my scars. I underwent female genital mutilation. Next slide, please. I underwent female genital mutilation when I was 6 years old. I tried to do my best in trying to get AI to depict the chair that we were forced to sit on. The environment looks very similar to this, very, very similar to this. It was a sandy floor. It wasn't a hospital. It wasn't somewhere sanitized. It was the front of my grandmother's house, where the only thing that gave us any privacy was the sticks that surrounded my grandma's house. When we were bought, or before we were bought to be cut, we understood Guditan, which is female circumcision. We understood to an extent. And when I say to an extent, I mean we understood that it was something required. It was something that was bound to happen, that it was going to happen. It was actually something that we all waited for, furthermore, because it was so normalized. It was so normalized that you wouldn't even think that there's something wrong with it. Like, none of us had the education that it involved between our legs. We didn't have the education that, there was something that was about to be cut. But what we did know is that girls who were not cut were shamed. They were tormented. They had people would throw things at them. Adults would curse at them, would say, oh, the girl with the clitoris, she's dead, she's dead. Don't play. I don't want my kids playing with her because she has a clitoris. But we couldn't understand what the fuck a clitoris was. And I'm sorry for the language, but we could not understand what it was. And we were almost kind of excited. It's like, I don't know what I could compare it to, having your ears pierced, how excited you would be, not fully knowing the pain that's about to come. But it's heightened by 1,000. When we were told we were going to be cut on the day, we were very excited. We, ran almost to my grandma's house because we were so excited. And then when we got to the house, there was a strange woman sat on a chair with another empty chair right directly opposite her. My grandma went and had a conversation with her, and I was smart. I was a very, very smart child, like street smart, because I knew never to, ever to go first in anything. Especially if I didn't know what was going on, I was not going first. I had to see someone else go first because I didn't know what it was. My little baby cousin was taken first. She went happily to this chair that you see. And then the moment she sat down, it was adults grabbing at her. And we had to watch her quite physically be held down with such a tiny body, trying to fight with all her might. Every time she tried to scream or plead or cry out, she had a cloth shoved in her mouth. And me and my sister made the decision, you know, when you're under pressure, you do things. We ran because we were like, absolutely not. I don't want to go through this. But by then it's too late. There's no way for you to back out. This woman is here and she's going to do what she came here to do. So we were brought back from trying to run. We were returned back to the house. And I think there was about, I would say, 5 adults there. My aunt, my grandma, my aunties, and my uncles, all holding a limb. You don't understand how powerful a child is when they're trying to fight for their lives. It's absolutely crazy to see. When we came back, she was being sewn together. They closed her legs like this and then tied a piece of cloth around it, really tight, picked her up, put her on the floor. I knew that it was going to be either me or my sister that went next, and none of us wanted to go. So we were fighting, and they dragged me to the same seat that my cousin just bled out on. Knowing what happened to her is about to happen to me, they held me down just like they did to her. And I can't describe to you how much I fought. Even my auntie till this day, when I question her, she says that she has never felt strength like that. And I'm like, no fucking wonder, because we were fighting for our lives. You know, I don't know where that strength came from, but I did not want to be cut. I saw blood and I did not want to experience that, because by then you know that something is going to be cut off. Long story short, they cut my labia minora, my labia majora, my clitoris hood, a part of my clitoris, and then whatever damaged skin was there or tissue was left over, it was brought together and physically sewn, leaving a small hole for urination and even a smaller hole for period flow and penetration. After being sewn together, because I can never describe what it feels like to be sewn together, it's disgusting. It is. I don't know. I will never be able to describe it. Hopefully soon, but right now I can't describe it because there's no feeling like that out there that I have experienced since. And they tied my legs together, put us down on the floor, did the same with my sister. And although we were all cut on the same day by the same woman by the same razor, probably on the same chair, I can guarantee you our cuts are not the same. The UK only knows type 1 to type 4, and that is it. They don't understand the concept that FGM survivors, even type 3, there are 2 other categories. There is type 3A, type 3B, and type 3C, which means each and every one of the survivors who've got type 1, it has type 1A, type 1B, type 1C. Same for type 2. But we've categorized all of these women into just one and trying to help these women as if they've all been affected by the same thing. But it's not working because all of our types are different. And these women need to understand what has been cut off them, what has been removed from them forcefully, so that, because with knowledge, you can begin to heal. But if you don't know what is missing and you're confused about the type that you've had, and even professionals are confused and they're telling you type 1, type 2, type 3, we need to give these women a definite answer of the physical trauma that they've experienced. They need to know what they went through. Each and every one of us, if our bodies have been affected or modified in some way, you would want to know what has changed. If you have a mental health issue, or you would want to know what is wrong with you. If you're suffering from a learning disability, you would want to know what specific disability you are suffering from so that you can get help. But if you don't know, you will live a chaotic life, you know? Next slide, please. The health professionals who have failed me, just me, and also every single survivor that I have spoken to in the last 4 years since I started my activism. And I'm talking thousands of women who have said almost identical thing no matter what country they live in. We face a system that does not see us or understand our pain. Teachers and educators. I have friends who I grew up with who never knew that I was an FGM survivor. Now they know. And I had a conversation because I was doing research for my book, and I wanted the perspective of a teacher who was from a practicing community, who was born in this country, raised in this country, was not cut, and who her mother is a FGM survivor. She is a secondary school teacher, and I promise you, what she said to me did not shock me in the slightest, because we're used to it. She said, I asked her about the training that she gets as a teacher, because you're just as important as doctors and nurses and midwives. So what is the type of training do you do? How long does it last? Is it effective, etc., etc.? She said, Shamsa, I have followed my mom to multiple appointments. I can't even begin to describe how my mom has felt over the years due to her FGM complications. She said, knowing all of this, having gone to all of these appointments, knowing the struggle that my mom is going through, she said, I am sat in all of those training sessions, listening to the most dehumanizing, basic, like almost senseless piece of information. She said, I could have researched that on Google and it would have given me a better knowledge. She said, even the one that we were supposed to have this year, nobody showed up. Nobody showed up. She said the slides are between 3-4 slides, talk about the prevalence. Is a woman of crime? That women are usually the perpetrators. The target is usually Black students. And you're completely excluding every single survivor purposely, whilst focusing purely on the Black community and not helping them, but targeting them, because that's what's happening. And then within the same breath, there are doctors and midwives, or even the head of gynecology, her name was Sarah. When the topic of reconstruction surgery, which is a life-saving surgery for us, when the topic came up, she said, no, we can't do more than defibrillation, because it's not going to benefit them. Yet we can do surgeries of a magnitude like reassignment surgery. So you're telling me somebody who has gone through reassignment surgery has benefits, but somebody who has experienced female genital mutilation is not entitled to reconstruction surgery? A surgery that can stop their complication, that can stop or further end their mental health issues, or they lessen their psychological problems. You're telling me, as somebody who has not survived it, who can't even comprehend it, you're telling me that I am not entitled to something because it does not benefit me. So I decided to go and have the same reconstruction surgery that the UK was denying me. So we talk about dehumanization. That is dehumanizing. We're expecting young women I am crying only because I know and understand the suffering of survivors, because they call me on a daily basis. I speak to these women on a daily basis, young women on a daily basis, who detail their suffering, who say, I want this surgery. I want my body back. I want my autonomy back. But their mental health is not considered. Their psychological well-being is not considered. And the only reason that is happening is because the idea is that only the Black community requires this. If all other communities needed this surgery, it would have been available. But this surgery is shockingly available in the UK. It's just not available to us. It's available to cancer patients, as if FGM survivors don't get cancer. As if we are immune to that disease. And even if an FGM survivor was affected by cancer, they still wouldn't touch her. They still wouldn't do the reconstruction surgery. Why? Because there's no framework for FGM survivors. So as an academic and as a survivor and as a social activist, how am I supposed to cope with the knowledge that I know that this surgery works for me? I underwent this surgery to stop the pain, in hopes to stop the pain, but more so to lead by example, to show the UK government that you can no longer tell me that this surgery is not effective because it stopped my pain, it stopped my complication. So continuously having to advocate for just basic human rights is absolutely insane, and it is heartbreaking, especially knowing that FGM went up by 15% since 2016. So clearly we are not doing something right. There is so much more that needs to be done, but nothing is going to change if you do not have in-depth education on female genital mutilation.
So I agree. I think we all agree. And Shamsa, I'm we're two speakers or three speakers deep at this point, and I'm feeling like we could have given you the whole 4 hours, or given Shez and Amanda the whole 4 hours. I apologize for interrupting. It's my pleasure to introduce our next speaker, Juliet Albert, Specialist FGM Midwife, BA Honors, Bachelor of Science Honors, RGN, RM, MSc, FRCM, NIHR. I'm sorry, I don't know what all of those acronyms mean, but I bet they're really hard to achieve. Clinical Doctoral Research Fellow. Juliet Albert is a specialist midwife for female genital mutilation at Imperial College Healthcare, NHS Trust, and runs the Sunflower Clinics for pregnant and non-pregnant FGM survivors. She co-chairs the National FGM Health Network and co-leads a project called ACERS UK, advocating for research and funding into reconstructive surgery and psychosexual therapy for FGM survivors in the UK. In 2008, she set up the Acton Well Woman Center, a community-based FGM clinic for non-pregnant women, pioneering a holistic model of woman-centered care, integrating bilingual specialist health advocates and trauma counselor, winning a Guardian Public Service Award in Diversity and Equality in 2011. Juliet designed a Royal Colleges of Midwives accredited de-infibulation workshop, has trained multiple healthcare professionals in de-infibulation techniques, and co-authored RCM's FGM e-learning package. In 2015, she was seconded as a project manager to the Department of Health's FGM prevention program, and in 2017, she joined Bernardo's National FGM Center as the head of community engagement and knowledge hub. She is published in several journals and book chapters, World Health Organization FGM expert consultation, and was made an RCM fellow in 2021. She is currently undertaking a doctoral clinical academic fellowship PhD at Nottingham University, examining specialist FGM care provision in the UK and other high-income countries of the global north. She is an expert in patient and public involvement and engagement, and is passionate about providing excellent healthcare to marginalized communities. Juliet, welcome, and thank you for being here today. I'll remind you that I'll give you a 3-minute warning, and just let me know when you'd like me to advance the slides.
Should I, is it okay for me to unmute now? Okay.
Sure,
Hello,
absolutely.
welcome. Hi there. I'm sort of, you know, I think it's quite overwhelming hearing Shamsa's story and thinking about how healthcare professionals have let her down. And I do think that there are lots of issues that we need to think about that come from that. And I don't know, I'm just considering how there are people in the US who are on this program and just wondering how that relates. So I'll try and bring in what my limited knowledge of that. So if you go to the next slide, please. So I am doing my PhD looking at FGM specialist service provision, but one of the other things that I think that my role involves advocating to overturn a social injustice. Next slide, please. This is just a picture of the team working at the Sunflower Clinic at Imperial College where I work. We have health advocates and counsellors in our team. We're very fortunate. Next slide. So firstly, I'm just going to be very quickly talking about what our service provision looks like in the UK, and then talk a bit more about why and whether reconstruction surgery integrated with psychosexual therapy should be available on the NHS, and think about what actually women want. So if we go to the next slide, please. So we know all of this already, but just to put it into context, more than 140,000 FGM survivors in the UK. NHS data showed that there were 33,000 women attended NHS services between 2015 and 2023. And in my research, I identified 28 specialist clinics across the UK. Next slide, please. I mean, the National Health Service in the UK is, I guess, significant just because I think it's different to how the healthcare system in the US works. And I think that this whole idea of free access to care is important to those of us, you know, working in the NHS. But we also do have a private system that operates at kind of a different level, but and obviously we don't have health insurance in the same way that they do in the US, that you do in the US. So I'm talking completely from an NHS perspective here. I thought it was just interesting to show you that we have nearly 50% of the clinics are located in London, which kind of makes sense because there's a higher prevalence of FGM survivors in London, but there are FGM survivors all over the UK, as there are all over the world. I completely agree with Shamsa. It's a heterogeneous group of people. It's not one person or one community practicing FGM. Everybody comes from an FGM affected community. Originally, you know, we're all originally from the same place. But what I wanted to show on this slide is that there's no clinic at all in Northern Ireland. So women in Northern Ireland, if they want to access the NHS, would have to come over to London or Bristol. There's one clinic in Scotland, one clinic in Wales. So women are having to travel a long way to access FGM specialist care. Next slide, please. If we look at commissioning or sustainability of services, it's also an issue. Services open and close quite regularly. Next slide, please. A lot of the services in the UK are, this slide it hasn't come up right. 70% of clinics are run by FGM specialist midwives, which is the 70% in red. But actually, I seem to have lost a little bit of that here. But the main profession is midwife-led, but there are some doctor-led clinics as well. So that would be an obstetrician or gynecologist, or perhaps a consultant in sexual and reproductive health. And there are a couple of GP-led clinics as well. Next slide, please. So all the clinical leads are female in the UK. Services are mostly embedded in maternity departments. 8 clinics are diaspora-led, and 30% of clinics are midwives working alone. So they will have a link consultant, but generally speaking, it's not a multidisciplinary team. They're working on their own, as Amanda was describing in Nottingham. Next slide, please. And as you can see, 56%, sorry, are services that is eligible for both pregnant and non-pregnant women. But there are some services that are only seeing pregnant women, like in Nottingham. And there are also some services that are only for non-pregnant women. So it's not universal access for all women. And some women are travelling, as Amanda said, from Nottingham to Leeds, which is a long way, for a procedure or even just for a diagnosis to find out what type of FGM you have. Next slide, please. So the survey showed that 10 services have no counselling support at all. 3 services have a psychosexual counsellor. 14 services have either a co-located trauma counsellor or a direct referral pathway to a linked trauma counsellor. 8 services have at least one health advocate. Most services offer defibrillation, but not all of them are offering same-day walk-in defibrillation under local anaesthetic. And so some women are waiting several months for defibrillation. Perhaps they are only able to access it under general anaesthetic. Again, some services are offering surgery for inclusion cysts, which is a complication that we see occurring very often with FGM survivors. And there's no access to reconstruction surgery at all in the UK. Next slide, please. I know there's a doctor called Marcy Bowers who does reconstruction surgery in California, but I don't know, other than that, how many other reconstruction services exist in USA. So what I found through my survey was that 76% of service leads report women had been attending and requesting reconstruction surgery. Over 60 women that amounted to in 1 year, and 5 different service leads had actually met women who'd already had reconstruction, but they'd had it done abroad, because, as I said, it's not happening in the UK. Next slide, please. So what is reconstruction surgery? There are 3 main aims of reconstruction surgery. One of them is to restore original genital appearance. Another one might be to improve sexual function, and another one might be to reduce genital pain. Next slide, please. And I wanted to show you a picture of the clitoral body because, I mean, I started working in FGM in 1998, and when I learned about FGM, I was told the clitoris had been removed for a lot of women. And actually, we know more about the anatomy and physiology now, and we know that it's only the tip of the clitoris, the clitoral glands, that's been removed. Now, when I say only, I don't want to minimize the trauma that comes from that, but I feel it's important that we inform women that their whole clitoris has never been removed during FGM. And in fact, some women still have an intact clitoral glands even after they've had FGM. So every woman is different. Next slide, please. So there are different techniques for reconstruction surgery. Sometimes it might be pulling up the root of the remaining clitoral tissue to expose it. It might be grafting tissue from other areas to make a new clitoral glands, or it might be creating the inner or outer labia, or a combination of all of those things. Next slide, please. And this is just showing you where these different techniques arose. Next slide, please. I can do a PDF afterwards if anyone's interested, so you can see these in more detail. So I think it's really important to say that there are many FGM survivors who do enjoy sexual pleasure. And next slide, please. There are also many women who haven't had FGM, who perhaps have difficulty enjoying sexual pleasure. This is a very complex subject, really. And there's many different aspects obviously involved in lovemaking. It's not only the physical mechanics, it's also the psychological aspects. And the clitoris is only one part of the body that's involved in helping women enjoy sexual pleasure. Next slide, please. So basically, because women were coming to clinic and saying, I want reconstruction surgery, and I just didn't know what to say to them, I started researching it. And I discovered that reconstruction surgery was available in many countries in Europe, you know, Spain, Belgium, Italy, Netherlands. And I was ashamed, to be honest with you. And so I rang a colleague of mine called Professor Susie Al-Neil. She's a Sudanese urogynecologist who works at UCH. And I said to her, this was back during COVID, in kind of end of COVID 2021. And I said, you know, nobody seems to be doing anything about this. Why don't we try and set up a clinic? So that was how ACES UK started. And we've made some progress. I think it's slow. It's, in fact, for me, it's excruciatingly slow, but we've got a battle on our hands. Next slide, please. So what is ACES UK? It's a female-led voluntary collective of FGM experts with FGM survivors, women with lived experience, healthcare professionals, midwives, doctors, therapists, psychosexual therapists, trauma therapists, health advocates, charity workers, campaigners, academics, activists, filmmakers, artists. So we're a funny old bunch. We meet every Monday, once a month on a Monday for an hour. and we're not a charity. We have got some money. We were given £10,000 by the Urology Foundation, but we're not a charity. We're just people who get together in our spare time and try and make things happen. Next slide, please. These are some of our members, and it's very humbling to work with so many amazing people who really just want to try and improve care for women. Next slide, please. So I've learned a lot through my PhD, and patient and public involvement engagement is absolutely key, and especially in this subject. So this idea is putting the patients, the women, the public at absolutely the centre of any research that's being undertaken, so that, because basically they're the real experts, but it also makes us accountable. It helps us disseminate what's going on, but so they're involved at every step of the decision making from the beginning of the project to the end. Next slide, please. And I think I know Sarah Crichton very well, who Shamsa was talking about, and this kind of medical view of the doctors know best. We tell the patients what they can and can't do. It's ancient nowadays. You know, what we need to do is give women the information and then let them make their choices themselves. And I think this is, luckily, this is translated also, or maybe this has come from research, actually, I don't know. But there's this change of focus in research as well, that it should be carried out with or by members of the public rather than to, about, or for them. And so next slide, please. So services should be redesigned, co-designed with women, with our FGM survivors. So the aims of our public and patient involvement was to understand what motivates women seeking reconstruction surgery, to explore the service needs and involve survivors in the work. Next slide, please. Why is this project needed? Next slide. So these are some of the drivers. Perhaps actually go to the next slide, because then I can talk in more detail. This is currently how we treat some women who attend FGM services. So really, often we don't really have much we can do. We can diagnose the type, we can do a safeguarding assessment, and if they're closed, we can defibrillate them. But there's a lot of women with clitoral pain or having difficulties with sexual pleasure, and it's very limited what we offer them. Lubricants, so lubricating jelly, hormonal creams, local anesthetics, physiotherapy. Next slide, please. But I feel very strongly that we should be able to offer them reconstruction surgery as well. So one of the drivers is women asking for it, requesting it. If we really want to provide patient-centered care, then we need to listen to what patients are asking for. I believe as well that by improving women's health, we improve outcomes for families and communities too, and ultimately this will then reduce the burden on the wider health system. Next slide, please. So as I said, there's no service in the UK. Now there are some countries in Africa providing reconstruction surgery as well, like Burkina Faso, Egypt and Kenya. In France, Pierre Foldes, they've operated on more than 6,000 patients since 1998. Next slide, please. As Shamsa was saying, you know, on the NHS, you can have vulval surgery if you've had cancer. If you have a condition called lichen sclerosis, you can get gender reassignment surgery for a man to become a woman. They're creating clitorises and labia for them, but we're not allowing FGM survivors to have reconstruction surgery. And in fact, there's a whole industry in the private sector around designer vaginas as well. And I think we have to acknowledge that women seeking surgery abroad, it's extremely expensive. And then sometimes they're coming back to the UK with problems afterwards. So the NHS anyway is having to pay in the end. Next slide, please. In 2016, the WHO said that evidence was low around reconstruction surgery, and they weren't recommending it. But they did say that available evidence shows it may improve chronic clitoral pain as well as dyspareunia symptoms. That's painful sex, that means. So while these results may appear promising, there was unacceptably high rates of reported complications, and there was concern about low follow-up rate and damage to neighbouring structures. But don't forget, this was in 2016, so this is now nearly 10 years ago. Next slide, please. And the WHO did say at the time they strongly encourage further research in these areas. Now, the problem in the UK is if we listen to the WHO recommendations, we would be doing research, but we're not doing reconstruction surgery. So how can we do any research into it? So we've kind of ended up in a chicken and the egg situation. Next slide, please. And the Royal College of Obstetricians and Gynecologists, which is quite powerful in the UK, they basically went along with what the WHO have said and said that they recommended clinical trials, but it shouldn't be performed because current evidence suggests unacceptable complication rates without conclusive evidence of benefit. Next slide, please. I want to make it very clear that not all women with FGM will want or benefit from reconstruction surgery with psychosexual therapy, but the lack of access to this, I believe, is a health inequality and discriminates against FGM survivors and is a social injustice. Next slide, please. So we want to basically set up a service, but we want it to be provided within a research setting. Next slide, please, so that provides safety and ethical consent. So the aims of our project was to review the evidence around reconstruction, co-design a new service with women at the core of that process, lobby policymakers, the Department of Health by setting up a parliamentary petition, publish our work so that it would be there to help support the evidence base, secure an NIHR grant, so an NHS grant, to fund the service and the research, co-create a web page and develop educational information resources. Next slide, please. Next slide, please. So these are talking about the different work streams. We have multidisciplinary group of surgeons, so plastic surgeon, urogynecologist, gender reassignment surgeon. We have our psychosexual therapists and trauma therapists working on this, and we have a patient and public involvement part of our group as well. So we've got some money and we have co-created a web page. We submitted our scoping review, which was published by the British Journal of Obs and Gynae. We've conducted patient and public involvement consultation workshops and held 2 national stakeholder meeting events. I'm trying to go really, really fast, sorry. Next slide, please. And we did launch our parliamentary petition, but we had a change of government in the UK recently. And so our petition with over 1,000 signatures got closed down. So we're going to have to reopen it shortly. And when I do, I'm going to send it to you guys. And I hope you're going to send it to everybody to sign for me. We've partnered with Oxford University Surgical Trials Unit. A small group of us attended an FGM reconstruction masterclass in Geneva, led by consultant gynecologist Jasmine Abdulkadir. We also visited Dr. Folders in Paris and observed 3 reconstruction surgeries. And we're now in the process of applying for funding to do a clinical trial, a feasibility study. Next slide, please. This is our paper published in the BJOG. Next slide, please. And what we found is there have been 40 publications that have talked about FGM. More than 7,000 women were reported as undergoing reconstruction surgery. 40% of them saw a multidisciplinary team, so not all of them. 15 studies, so under 50%, provided psychosexual counselling. And these are some of the improvements that they found. So 97% of women reported an improvement after reconstruction surgery. 37% in sexual function, 35% pain, 69% body image, 64% vulval appearance assessed by the woman, 90% vulval appearance assessed by the doctor, 76% increase in intimate relationship, and 78% self-esteem. And there were only complications noted in 3.9% of studies. So that was 309 women out of all of the women that underwent surgical reconstruction. Next slide, please. I wanted to very briefly talk about the example of one of the care pathways in Belgium called SEMAVie. And why it's important, I think, is, go on to the next slide, please, is they've tried to incorporate for every woman that she has at least one session with a trauma therapist and at least one session with a psychosexual therapist before she accesses reconstruction surgery. Next slide, please. And what they found from their work is there were no deaths and no life-threatening complications. Healing sometimes can take a long time, so even more than 12 weeks. The pain can be very severe and it can trigger upsetting memories. And there were sometimes some short-term complications that you would imagine with any surgery. Next slide, please. So we want to do it within a research setting so that it contributes to the evidence base, to ensure accountability, strict ethical guidelines, so the work's closely scrutinized, and also to pay for it. Next slide, please. Why do we want to integrate it with psychosexual therapy? Because in the UK, there are very few psychosexual therapists in FGM clinics. What the research tells us is that about 1 in 5 women after psychosexual and trauma therapy then decide they no longer want surgery. And also, all surgery does carry some risks. And so we just want to make sure that women have as much education and support before therapy that they need. Next slide, please. So this is talking about this ladder of intervention where they have lots of access to trauma and psychosexual assessment, education and therapy, and non-invasive treatments before accessing surgery. Next slide, please. So we're trying to set up a feasibility study. We're hopefully applying in April next year. And yeah, watch this space. Next slide, please. This was our petition when it was running. Next slide, please. And if you get 10,000 signatures, the petition's important because if you get 10,000 signatures, the government have to respond. And if you get 100,000 signatures, there's actually will be a debate in Parliament to discuss it. So that's why we want to do it. Next slide, please. This is our web page. It's on the Royal College of Midwives FGM Specialist Network website. Next slide. And we've held 2 focus groups and 2 national stakeholder events. Next slide, please. So this amazing artist called Ida, she's produced this art already. It's not just for our event, but she showed her art at our event. And this is just some of the things that went on. So for example, on the top right-hand side, we had an Arabic and a Somali speaking women who are translating for us during the presentation, and that at the bottom left is Professor Susie Al-Neil talking, and these are some of she's made these beautiful models that we use in our FGM clinic to explain the different types of FGM with women. Next slide, please. This is more of her artwork. We had a virtual Q&A with Jasmine Abdul Qadir, the consultant in Geneva, and women were able to ask questions about how long does it take to heal, what are the side effects of the surgery, that kind of thing. Next slide, please. And like you, we made sure it was a safe space. We had our counsellors all present at the event as well in case it was triggering for any women. This is the pictures of us attending Pierre Folder's clinic in Paris, and these are the posters from our event advertising it. Next slide, please. And this is the British delegation was 2 of us, and then 2, a midwife, Huda Mohammed, as well as Aurora Al-Madouri, who's a plastic surgeon. They attended virtually, and that's myself, and Dalia Saeeden, who's a urogynecologist. We attended together. Next slide, please. These are just, again, talking about the masterclass in Geneva and who was on the scientific committee there. Next slide, please. And these are our charity partners. I'm proud to say that we do have lots of support for the work that we're doing. Next slide, please. And this is, as you can see, the Oxford Surgical Trials Unit, Royal College of Midwives, and the Faculty of Sexual and Reproductive Health. Next slide, please. And that's just a picture of us at the end of the most recent event. We had 89 attendees. Next slide, please.
So we have another minute or 2, Juliet, because I know there are going to be a lot of questions.
Yeah. Next slide. I think that's the end. So I have more slides, but it was to explain the patient and public involvement event. what it's explaining is there are some quotes from women, because when we did our event, we firstly did some discussion around anatomy and physiology, and for some of the women, some of the quotes are just women talking about what they learnt through that education, but also what their motivations were for seeking reconstruction surgery, and how they felt about FGM in general and the care they received in the UK.
It is now my pleasure to introduce Dr. A. Renée Bergstrom, ED.D, educator, Somali women healthcare advocate, and artist. She's a female genital mutilation survivor and activist who counsels medical students and physicians, and lately nursing students and medical imaging students as well, right, Renée? How to interact with patients who have undergone the procedure. Her career as a patient education specialist helps her to develop innovative curriculum and resources to equip clinicians with the knowledge and skills to provide compassionate care to survivors. She holds a Master's of Education from the University of Minnesota and a Doctor of Education from St. Mary's University of Minnesota. Dr. Bergstrom received the 2021 Survivor Activist Award from the Global Peace Foundation. She recently became a 2024 Public Voices Fellow on advancing the rights of women and girls with the op-ed project and Equality Now. Welcome, Renée. I'm so glad you could join us today.
I am just getting over a respiratory flu, so my voice sounds a little weird, but I will go through what I talk to medical students about, and that is my history of interactions with doctors and how they could have been handled differently. So, when I was 3 years old, that was in 1947 in Midwest America, my mother was concerned that my little face turned red when I touched my genital area. So she took me to a doctor who said, well, I can fix that. And he was Seventh-day Adventist, and this religion had a long history of opposition to masturbation. And so he practiced his religion with a scalpel and cut off the external clitoris. And my mother knew immediately that it was a mistake. But I felt the pain and I felt betrayed because she was at the end of the table when this was happening to me. She held me until I quit crying, took me home, and told me to never talk about it. And talking to other survivors, this is pretty much universal. Every little girl is silenced, as if it were our shame instead of the shame of those who have done this to us. So in some ways, I lost my childhood innocence, and there was a role reversal because now I was my mother's protector, and secrets can make you sick. one of the consequences of being cut was some of the sensitive tissue adhered to my inner labia. So I had this very uncomfortable tugging sensation, and it wasn't constant, but when it happened, the only way I could relieve it was by rubbing my legs together in another form of masturbation. When I was 15 years old, as soon as I got my driver's license, I drove up to Wahpeton, North Dakota, to our family clinic, not realizing that this is where I was cut. And I came in and said to the doctor, some stupid doctor cut me, and now I have this terrible sensation, and can you do something to relieve it? And I don't think he even examined me. He gave me a brochure on the sin of self-pleasuring. And if he had actually listened to me and sort of opened the scar, I would not have had the complications that continued. When I led a very happy childhood, teenage years, but when I was 18, my brother died in an accident, and in grieving his loss, I also began to grieve the loss of my body parts. So this late teen years were difficult. I was married when I was 21, and back in those days, I have no idea what this was about, but women had premarital physicals. And so I said to the doctor, I don't know if I will be able to have orgasms like regular women. And he sort of turned his head to the wall and didn't comment. And I got this sense that doctors were protecting the doctor who did this to me. I was 23 years old when I had my first child, and I wanted to be awake, experience the whole thing. Second stage labor stopped because my scar wouldn't stretch. And so I was anesthetized against my will. I didn't wake up until 4 hours after my daughter was born. I didn't see the delivery room at all. And at that time, we stayed in the hospital for 5 days. The doctor never mentioned that there was a problem. 6 weeks later, I had my physical and then began resuming sexual intercourse, and it was painful and my vagina was lumpy. So I went back to the doctor, who brought an anatomy book and said, Renée, you don't look like other women. And he thought I'd had a bike accident or something, and he was shocked when he heard that a doctor had done this to me. Now, if he had, no, he was very kind, he was very compassionate, but he didn't treat me as a partner. And if he had discussed this with me when my second stage labor stopped, we may have been able to have opened the scar. Then actually I had 3 children in less than 3 years. And when I was pregnant with my first son, my original obstetrician had left town, and the next one was really rather rude and disgusting. And he kept suggesting that he could connect me with Masters and Johnson, who were writing a book on human sexuality, and that he thought they would find it very interesting to just examine, or I don't know how, see at what level of orgasm I was experiencing. So month after month, he kept suggesting this, and I kept declining. Then when my third child was born, I awakened as he came through the birth canal. He began to urinate immediately, and the doctor held him up so he peed in my face. And this, I didn't get to hold any of my babies immediately after birth. And I just feel that the whole experience of being cut took away a lot of my possible experiences as a woman. I still was keeping silent, so I felt very alone, and then I couldn't talk to my friends or sisters about my birthing experiences without exposing everything else. We moved to a small town, and our house was right across from a church. And one morning I looked out at those stained glass windows and began to sob, realizing that religion had played a part in my being cut. Not my religion, the doctor's religion, but still, I talked to a pastor and who referred me to a therapist. And so finally, in about 1970, I began to have the emotional help that I needed. In 1981, I saw two things in papers on the same day. One was that African leaders were planning to convene to decide if they should be bringing FGM into the clinical setting to prevent some of the infections and deaths that were happening in the bush. And on the same day, I saw an application for a grant from the Women's Desk of Lutheran World Federation for people who wanted to do education on women's issues. So I applied for that, and I was not allowed to go to the African conference. I mean, the leaders wouldn't allow me to come. But the Women's Desk invited me to Geneva for 2 weeks. And prior to that, since I hadn't been speaking out, I went to the University of Minnesota's Week of Enrichment, which was for doctors and pastors and other people who might encounter different forms of sexual practice. And when a surgeon there from Minneapolis, St. Paul, I'm not sure where she was from exactly, found out that I was there, she came and offered to cut off one of my nipples to create a clitoris, and was really angry when I declined to be part of her experiment. And so I just feel like no one has a right to experiment on another's body without, because what I asked her was, how are you ever going to connect the nerve endings so it would actually serve as a clitoris? And why should I have another mutilation to try to correct one? And I couldn't imagine that it would work. When I was in Geneva, I spoke with Maria Assad, who was then known as the Egyptian gentle warrior, and she was the Secretary General of the World Council of Churches. And she was working very hard to end FGM in Egypt. And many, many, many years later, it was able to be discussed on TV, but it took a long time. When I went to, on the weekend, since I'm a weaver and a spinner, I went into the Alps to a little village, and halfway there, when I had to switch from train to bus, there was a castle on the hill that I walked up to it, and it was an art gallery. And I went through and up a turret onto a patio, and there was a statue, a bronze statue that looked exactly like my brother, who had died 18 years earlier. And I felt like God was giving me a hug, that what I was doing in FGM activism was to be the direction for my life. So I came home and went back to school while I was raising teenagers. And because I thought someday in my life, I will be able to address this, and I wanted to be credible. Some women from Africa in Geneva said, Renée, go home and work on your own culture, and then come back and we can discuss what works for us and what works for you. And that is quite a challenge, because there are young women in conservative evangelical Christian communities that are being cut today, and their little girls are being cut here in America. And I hope that someday we are able to find a way to stop that. A couple of other interactions with doctors. My children were track stars. And at one track meet, I fell on the bleachers and had a hematoma in my genital area. I went to an ER doctor, and who for some reason suspected that my husband had kicked me or something. And because I said, well, it looks like I'm not going dancing tonight. And she said, well, I hope you wouldn't go with him. And she seemed stressed. And 2 weeks later, we read that she had driven about 100 miles and walked into a lake and took her life. She was young and beautiful. And what I tell medical students is, if ever you are overwhelmed by what you are facing in your practice, suicide is not the answer. Find help, because there are some pretty terrible things that you are going to be running into, and we need support. Another time that I had an interaction with a dermatologist was when I had a boil down in that area, and she was extremely angry to find out why I was different. And it felt good. It felt like a relief that she was no longer protecting whoever. She was not protecting what had been done to me. But I caution medical students about that kind of reaction. First, find out how the woman feels about it. And if her culture, and she goes along with the cultural belief that this is positive, it's inappropriate to be angry, but just to listen and be supportive and compassionate. In the 1990s, as my job as a patient education specialist was to, I was to make a equal pros and cons brochure on male circumcision. So I went to a no-cert conference in Maryland, and I met a Somali woman there who had developed the video Fire Eyes. And she had been later threatened by her community, and so she had to hide to save her life. I shared my story. I was not on the agenda, but I shared my story there, and it was videotaped. Back home, I shared my story with a church member and 3 different members of my cohort or co-workers that I thought were compassionate. And all of them told me to never share that story again. Some of them said it would ruin your career. How, I do not know. And as a very compassionate male physician said, it must have felt like being mutilated all over again to be silenced. After getting my doctoral degree in 2008, I became an adjunct professor for Winona State University, and I taught feminist spirituality for women and men, and I had a couple of Somali students, and I had them do sort of a timeline of things that happened in their life that made a big difference. Not that you could change it, but something that impacted them spiritually and in other ways. And the Somali woman noted the day she was cut. And so I wrote on her paper, happened to me too, let's talk afterwards. And she and I developed a brochure for infibulated Somali women to give to their obstetricians or midwives early on in their pregnancy to plan labor and delivery, and basically showing how to cut the scar or de-infibulation. In 2016, John Chua from Richmond University in London somehow found my video that I had done in the 1990s and found me in Lanesboro, Minnesota, and came and interviewed me for his documentary, The Cut. And in December of that year, a portion of that video was in my story that came out in The Guardian. And I was in Washington, D.C. at the time at an Ending Violence Against Women's conference. And someone there said, Renee, are you on Facebook? And she put my story on my Facebook page, and this is how my grandchildren and a lot of my friends found out. And it was actually a good thing, because I would have told the kids, but their parents didn't really want me to. And since my story came out, other women in the United States, white women from Christian cults, have reached out to me. And the first question is, you mean this doesn't happen to every single woman in America? So they are very controlled, and this needs to end.
It is my honor to present our final speaker of today. Lynne Gotjen, PhD, MSN-RN, is the Dean of Nursing at Maine College of Health Professions. Dr. Gotjen has served as the Dean at Maine College of Health Professions since 2017. She earned her doctoral degree in psychology in 2013, where she honed her leadership and interpersonal communication skills. Her diverse career includes roles such as clinical director of nursing for an assertive community treatment program at Maine Behavioral Health, psychology associate at Spectrum Behavioral Health in Maryland, and director of allied health programs at Anne Arundel Community College. In her role at MCHP, Dr. Gotjen finds fulfillment in fostering an environment where personal and professional growth is actively supported. Welcome, Lynne.
Thank you, Anne, very much, and thank you, Renee and Shamsa. What powerful testimonies! You're brave and brilliant, and I very much appreciate hearing your stories and being part of this presentation today. So thank you. And next slide, please, Anne. So with all the wonderful things that I have heard, I am very happy to know that somehow some of what I've come to believe to be true for counseling is actually effective. So that's really good to hear, and that'll become more evident as we go through the presentation. But clearly, we've talked about the psychological manifestations of FGM, and they're lifelong and clearly needs to be something that's addressed as with any other trauma. And this slide is just the World Health Organization also commenting on the unspoken suffering stemming from this traumatic experience. Slide, please. Just the facts, they've clearly been stated already. I think it's really important when interacting with patients, and my presentation is really going to be coming from a counseling perspective. We know the facts, and it's the facts don't necessarily always, they're not always meaningful in terms of how we approach the patient. And I'm going to just have you go through the next couple of slides, actually, Anne. If you keep going. Okay, maybe one more. So with the prior slides, I just commented on the fact, and people have touched on this already, about the intergenerational abuse and how that affects all societies, not just those where FGM is occurring, and how if we can actually get to the root cause, get to that child who has experienced the abuse and work with that child, then there is the much greater opportunity of breaking that cycle of intergenerational abuse and talking about that. So this work is not only important for survivors of FGM, but survivors of other types of abuse as well. And as a clinician, knowing how to interact with people who have suffered from these traumatic experiences. We talked about education, critical. We do what we do because we think the way we think. So how do we change the way we think? We get more information. And information is the power that we need to start acquiring a different perspective. Because again, we are experiencing, or we're being told that a lot of people aren't aware of what the practices are of FGM and what the manifestations are, or that they even had it done. So being educated is critical. Next slide, please. When dealing with patients, it's very important to be self-aware. What are my values? What are my biases? What are the things that are going to perhaps influence how I interact with the patient? They really are irrelevant. I need to put those aside, because what I need to do is approach the patient from where they are. That's the general rule in healthcare anyway. But I think in this particular case, because I am Westerner, I don't, and it is happening here, I'm learning, but I don't understand. And so my approach to this is going to be perhaps very different. And I need to keep my perception or ideas neutral so that I can provide priority help to my client. Next slide, please. So how do I do that? I have to maintain constant vigilance. I have to challenge my own personal assumptions, which this presentation has been perfect for that. Provide evidence-based information and remain empathetic and provide judgment-free support. Next slide. So to continue on with how I prepare to interact with the patient, risks and safeguarding, this has already been something that's been talked about. We have to ensure that our clients are safe, that policies are in place to protect them, protect vulnerable populations. At the same time, the safety that will foster trust, informed consent, comprehensive informed consent, so that a client knows what will be used, it's their decision, what information is shared. So I think that's also a critical point to make. Next slide, please. We also have to consider the context of when we're engaging with different clients. What's the cultural background? Not just the cultural background across the board, because that's not the case, but geographically, what is the cultural background? What are the legal implications? What's the social environment? What experiences, in addition to the FGM, is that person undergoing? And I think it's interesting to note that in the research, the number one factor that continues FGM is social pressures. And so that social environment is extremely important to understand, or requires much understanding, but also I think a good part, a segment of the therapy is to help an individual to be able to make those decisions from within, as opposed to based on environmental pressures and constraints. Next slide, please. Just a diagram of all the different aspects of a survivor's identity. And I thought it was very, I think it was Shamsa who said it, that it's not just speaking from the survivor, that identity. There's so much more than that goes to that with that. And I think that's critical to remember when interacting with patient. Slide, please. So as we begin to approach the patient, a cognitive shift or changing the perspective regarding the practice of FGM and cutting, that not only is for educating healthcare professionals, but perhaps for the patient as well, in terms of even understanding that it's abusive. I was told the other day that a patient learned for the first time from a nurse that it was actually a form of abuse. So the patient shifting their perspective as well. Next slide. Thank you. So how do we approach individuals? I love Carl. He's the humanistic theory of person-centered therapy, working with survivors. It's critical to utilize the principles of person-centered therapy, addressing the survivors' individual needs, protecting them from harm, and empowering them to stand up for their rights. And this is through everything that's already been mentioned from the individuals who have spoke today. Empathy, listening. What does it mean to really listen? Meeting the client where they are. I don't have any idea what their story is. I can only know by listening, and listening empathetically, because we hear a lot of emotion when we listen, when we actively listen. Next slide, please. So Carl Rogers, he is the one who developed the humanistic theory of therapy. He did most of his work in 1959, 1960s. I should say the work that I feel has had the greatest influence. And again, his theories are of meeting the client where they are. Also genuineness from the therapist, as well as facilitating genuineness from the client. And that can be through self-disclosure. As we all know, vulnerability, when you're willing to be vulnerable, miracles can happen. So sharing part of oneself, if that's appropriate. Unconditional positive regard. Scott Peck is also another one of my favorite psychiatrists. He's written several books, and he says that you have to love all your patients, and I 100% agree. I love my patients, and love brings miracles to it. When you can shine that on the darkness of trauma, miracles can occur. Next slide, please. So, according to Carl Rogers, people are evolved towards self-actualization. As long as we can help, or they can remove the barriers that are preventing them from growing, then they will continue to grow into their best self. When there are barriers, and when something happens that interferes with that experience of growth, then pathology can occur. And so the goal, in his eyes, of the therapy is to help to remove those barriers so that the individual can find their way. And it's a matter of sort of standing by them and walking with them as they find their way. Next slide, please. So according to Rogers, there's two primary sources that influence our self-concept: childhood experiences and evaluation by others. Right there, you have it with FGM. It happens in childhood primarily, and there's the social pressures to continue on with the practice. So what does that do to self-concept? You know, as Renée was saying, with the continuous disrespect and isolation that she experienced, it's the pain that is associated with that had to be profound. Next slide. So the components of self-concept, self-worth or self-esteem, that's the value that an individual places on themselves, and it's influenced by perceived successes, failures, how they believe they're viewed by others. And again, Rogers believed that the feelings of self-worth developed in childhood and were primarily formed by the interaction of the child with the mother and father. Next slide. Second component is individuals' mental representation of themselves, and that's shaped by the personal interactions with other people. So body image, being a good or a bad person, it is how we see ourselves based upon how other people treat us. So if we perceive that other people are treating us poorly, then we are going to take that on and assume that that's who we are. Next slide, please. He goes on to say that self-image versus real self is a constant battle, because we all internally are aware of our value. We just have to get back in touch with it. It's the thing that drives us to grow and self-actualize. It's just been it's been covered over. So there's a battle between that self-image based on our experience versus our self-awareness, and it's that incongruence that makes people have anxiety and depression and distress. Next slide, please. So the ideal self is that version of oneself, again, that we are all aware of. It's what we aspire to be. It is what, as I said, the driving force that we continues to make us want to grow and be better. So a goal in the therapy is to help people to bridge that gap between the real self and the ideal self, and that will help to create overall life satisfaction. Next slide, please. So what we're talking about there is really getting in touch with the internal strength that every survivor, I've seen it, I hear it when you talk, that you all have, and in any type of therapy that you're doing, helping people to recognize the incredible accomplishment of walking through life in spite of the trauma. You aren't the trauma. You are who you are in spite of the trauma. And I think that I just wanted to also touch on what Shamsa said about, you know, grieving, and I think actually Renée as well, just grieving that child, that loss of that child who in a split second was robbed of their childhood, as well as their the things that are associated with what it is to be a woman, and the everything that goes along with that. So I think just grieving that loss is very important, because that child is still there and that child's still wounded. So getting in touch with that child and mothering that child and loving that child and letting them know that they did nothing to deserve that they are, you know, that they're lovable, all those things that that child was kind of left wondering about on that day when they were so severely violated. So mothering that child, loving that child back, and telling them that they're safe now because you got it. You got their back. You're going to take care of them now. That's critical to work through that in the healing process. Because the truth is, you really can't have a relationship with other people until you have that relationship with yourself. So that has to be addressed. Not that you stay stuck there, but you make that connection. You love that child. You love that part of yourself that's lovable, and you move forward. So that is the approach that that I would carry. Quite frankly, I have not interacted with somebody who's gone through FGM, but what I would do, having worked with survivors of trauma, is a combination of the survivor-centered approach and the trauma-informed approach, and I'll just go through those, what those are briefly. So the survivor-centered approach, both of these approaches are really based on framework of what Carl Rogers says in his humanistic therapy theory. Want to enhance emotional well-being, increase the feeling of safety, empower survivors as they navigate trauma, make decisions, and assert their rights. Survivors are at the center of the intervention. They're making the decisions. They're guiding the therapy. And in my experience, when you allow people to talk and you listen, that's what happens. They realize what decisions they want to make, and they also start to appreciate the strength that they have and the ability that they have to move forward. Next slide, please. The goal of the survivor-centered approach is to shift the power dynamics. So enhancing the survivor's autonomy, enabling them to take control of their bodies and lives and make informed decisions. Builds confidence. So fostering that self-worth, that confidence through the healing process, and establishing mutual support networks. Sharing your experience, strength, and hope with other people is what works. You realize that you're not alone, and that's not just with FGM. That's with so many other things that we struggle with in life. Having other people to talk to that have gone through a similar experience gives you strength. And in FGM, that's obviously extremely important. Facilitating skill development, empowering people who have gone through FGM with skills and knowledge, enabling people to seize opportunities, priorities, make decisions that will benefit them, like reconstructive surgery, if that is what they choose. Next slide, please. Why do we engage survivors? Obviously, to provide essential support services. They're going to tell us how we should approach helping them. They also have the context-informed solutions, which are going to lead to more sustainable outcomes. They know the culture. They know what they are dealing with, and can help us to help them. Next slide, please. So with survivor engagement, prioritizing well-being and autonomy, making their own decisions. Again, actively listening to experiences, offering support, which helps to help them find their voices. Because once they become in touch with their sense of self and really realize who they are, they find their voice. And that is going to be the thing that is going to start making changes in these practices. It's going to come from the people who have gone through it, standing up and doing what you're doing, advocacy and activism. Next slide, please. So survivors have a right to confidentiality. Again, no information should be shared with any third party without consent. So critical in working with an individual who has gone through any kind of trauma is trust, and that cannot be broken. Trust, respect are absolutely critical. Next slide, please. Safety. People are not going to share if they do not feel safe. And, it might be a while before a person feels safe enough to start talking and trusting that you're someone who can help and that you want to help. Also, non-discrimination. Everyone fair treatment, regardless of culture, regardless of age, gender, race, all of those things. We are all potential victims of a violent act. There, as Shamsa said, there's no one that it has a pass on that. Next slide, please. So for trauma-informed approach, again, empathy, understanding, respect, and again, walking the individual through the personal healing process, meeting them where they are. Trauma, significant emotional and psychological support is clearly going to help to lead to empowerment and help to cope with what has happened. So through trauma-informed lens, ensuring responses so that we don't unintentionally reinforce feelings of vulnerability and disempowerment. And that's very important. Next slide, please. So as far as short-term consequences, and I'm sure there's many more, emotional and psychological shock, particularly from being subjected to this trauma by people who are close to the child, parents, extended family. I can't imagine being excited and think I'm going to a special event and then undergoing such a traumatic experience. That is profound. Next slide, please. As far as long-term consequences, PTSD, depression, anxiety, low self-esteem, self-disgust, shame, humiliation, difficulty with relationships, and that is why it's very important to grieve the losses that victim has experienced, not victim, a survivor has experienced, because a lot of the compensation mechanisms create relationships that are not healthy. A person who has gone through a trauma oftentimes will become very controlling because of the sense of loss of control. So working through those issues, working through the self-image issues and really challenging those, again, that cognitive restructuring, challenging those feelings of shame and humiliation that were not at all created by anything that has to do with you or with the survivor. Compulsions can be the result, and addictions, anything to kind of numb away that pain, again, if it's not dealt with. So this type of counseling is so important to help to alleviate some of that pain that continues on psychologically. Next slide, please. So the principles, again, it's all really very similar, is safety, trustworthiness, and then peer support and mutual respect. Survivors will become empowered, and that is what the goal is, for them to become empowered and find their voice. Next slide, please. So collaboration, mutual healing. This again is understanding the impact of the trauma and collaborating with the survivor to walk through to the other side, helping to find voice and choice. And this is obviously not as easy as it sounds, because if we're talking about social pressure, not everyone is going to be thrilled that the survivor of this experience has found their voice and that they are now speaking out. There are going to be people that are going to be threatened by that and provide pushback. So being able to be empowered to speak is going to require support, not only from therapists, but from helping connect with different support groups, with people that have gone through the same thing, who can share their stories. A long-term goal is eliminating stereotypes, integrating the healing value of traditional cultural connections. And that's going to be critical for people who are coming from different cultures to be able to bring back this information and engage their culture in the healing process to stop this practice. And I already talked about this, but can't emphasize it enough with voluntarily making sure that survivors know that that their consent is given freely, that it's comprehensive, and that you explicitly agree to participate. People have mentioned holistic care, and I think that that's really what I'm wrapping up with. Ensuring safety and confidentiality, which is, what is that doing? That's respecting our client, making sure they're safe, making sure that they know that they can trust us to protect their information, offering medical care that addresses those immediate health complications that result from FGM and the more chronic complications, listening to their choices and their desires if they do want to move forward with reconstructive surgery, and knowing that that's their choice. Psychological support, offering that counseling and therapy, helping survivors cope with the trauma, with the anxiety, with the depression, with the self-image, primarily the self-image, because if a person is able to get back in touch with their God-given nature and with who they are, then those decisions that they make and that empowerment, that strength comes from within. And there is a power that really is able to combat those social pressures that cause the perpetuation of this type of abuse. Next slide, please. So finally, survivors, 200 million survivors raise their arms, victorious voices break centuries of silence, and solidarity transforms pain into memory. This is the world dreamed of by the women leading the movement to end female genital mutilation. This is the world they will create. This is the world you're creating. And your courage and your bravery, for those who spoke, is awe-inspiring. And I thank Anne for Susie for letting me be part of this and to learn from this, because it's been a wonderful learning experience. And I hope what I have said has helped a little bit as well. Thank you.
Thank you, Lynn. That was wonderful. Right. In the interest of keeping to our time, our speakers today, some of our speakers today shared the resources that you see here. We wanted to let you know that we will be emailing everyone's email. We'll be sharing the PowerPoint and the video, so you will have access to this. You don't need to worry about capturing this information now, but there is some fantastic resources shared by our speakers, and we appreciate them giving us that information. And these are our references. Susie, did you want to say anything before I do my last little bit?
I just wanted to say a huge thank you to everyone for coming. I think I know for me it was quite an important moving day, and I really hope that everyone got a lot out of it, which I think they did from what I've seen so far. So I just want to thank everybody and thank our speakers, especially because it's a lot to share, and it's, especially for Shamsa and Renée. And so thank you very, very much for being so open with everyone. It makes a huge difference.
I would echo everything Susie said. Thank you to our speakers. I can speak for myself. My life and my practice is enriched by what you shared. So thank you. You make a difference. And I want to thank everyone who came today. I'm umming because I'm getting emotional. It's hard to be witness and to hear the experience of others, and that have been so difficult and so hard for me to wrap my head around and to wrap my heart around. So again, thank you so much for sharing. I want to just acknowledge that it might be hard for others as well. So as we kind of move on to the rest of our day, I'm sure we'll be reflecting a lot. Please do take care of yourself. You are worth it. You are important. So please reach out if you're stressed or you need to talk about things that today brought up. And again, we'll be emailing a copy of the session to everyone. You'll also, that will take a little bit, but in the short term, you'll receive an evaluation about today's session, and your feedback is everyone's feedback is very valued and important. So with that, I think we are done. Thank you so much, everyone, and take care.